time it is. Marvin Devine, Huber, Axel, and you know how we do. Yeah, I got the juice. Whip game cool, make them look like cool. Always play it cool, that's the biggest rule. Forget what they doing, keep on doing. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, just wanna get in my crew, but you can't get in my crew. Me, XL, and Huber, way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we link up. Let's go. Yeah, I got the
Good afternoon, good morning, good evening, wherever you're watching. Welcome to another broadcast of Kidney Hub East Africa. I am half your host, Steve, the Kidney Nurse. First, I want to extend speedy recovery and well wishes for my host, half of the host, Moses Kennedy, the kidney ambassador. Right now, he is under the weather with the flu. So please send your prayers and blessings to Brother Moses Kennedy, the kidney ambassador. Thank you. Now today, we got a topic that we talked about many times. And in fact, when it comes to dialysis education, you'll see a lot of repeated topics, not just here, but in the dialysis center. Emergency evacuation, caring for your access, dietary stuff, going over your labs. What else? Caring for your access. Many things that they talk about, and you'll be in the clinic say, we just went over this last year. So yeah, we had to do it each year. Certain education, infection control. Now, if they didn't do that, new people that start dialysis would miss out on that information. Will miss out. Like no one told me. So today, we're going to talk about how to care for your dialysis access, something that's rarely talked about. And see, if you go to outpatient dialysis, this is something that we used to be able to sit down with the patients and go over this information. But the way that these corporations have designed the operation inside the facility, it doesn't give the professional an opportunity to sit down and talk with the patients and do education. Because as soon as you take one patient off the machine, they want you to hurry up and get someone else on there. And it's many reasons. They want to keep personnel off the clock. The machine is available. It's almost like get them in and get them off. So we missed the opportunity. So let's get into this. How to care for your dialysis access, what you should know. And let's start off talking about catheter. This device right here. Now, did you know that 4 out of 5 patients begin treatment with a dialysis access known as a catheter? And then, you have your patients that may get access put in a year before they start dialysis. Some doctors catch patients like that. They may be in stage 4, right? And I'm not saying that's bad or good, because I had some patients that waited. But you may have some patients, doctor approach them, they in stage 4, and say, hey, I think we should put a fistula in your arm just in case things go south and you got to start dialysis. And at least you will have the access in your arm. And for many people that don't know about dialysis, or this is just hit their life, they may think that that's a good idea. So they start, whenever they start dialysis, they already got the access. But those are very small minority of people. That's why they say 4 out of 5 patients begin with the dialysis access known as a catheter. Now, typically, these catheters are placed in the chest area in the hospital for a short-term solution for emergency dialysis. Soon as your kidneys fail, or you go to the hospital, you sick, and you go to the ER, and they come back with the papers. Did you know that your kidneys are failing? Like, no. Okay, so what we got to do is we're going to have to put in a temporary catheter. Whether it's this or the one in the neck, the IJ, the jugular vein. Either way, they're going to put something in your neck so they can get access to your blood to begin dialysis immediately. Now, catheters, these are often considered temporary way of receiving dialysis. Now, you may ask, and let me say this, just because this is temporary doesn't mean it stays in temporary, because I know many people who could be watching this right now and say, Steve, it's not temporary to me. I had mine in for 3, 4, 5 years. And that may be because of vascular issues. So one has small veins and they exhausted where they can create an internal access. Or they flat out refuse to get it taken out because they don't want no cutting on their arm. Or they're waiting for a transplant. Now, if you're in East Africa and you're watching this, I don't know how the process goes there. See, that's where we're missing the other half of the host, Brother Moses, who is himself a kidney warrior. And he's been through having a catheter and recently getting a graft put in his arm. So let's talk about why is a catheter often a temporary access. But like you said, you can have people watching this right now and say, Steve, I got my catheter. I had it for 1, 2, 3 years. But this is why they're often temporary. Typically, catheters should only be used for a short period of time. This is because there is a higher risk for dangerous bloodstream infections due to the placement of the catheter near the heart. And if you've been on my TikTok lives, you see me show the picture of this catheter and how it goes into the heart, into the vein, and this tip sits in the heart, in the back of the heart chamber. And when you have this, and you have personnel that may be working on you and cleaning the access, this is where you got to say, hey, please, if they didn't change their gloves, wash their hands, mask over their face, especially when they pull off your old dressing, they should be changing their gloves and putting on new gloves to use the clean stuff to now clean your access. Listen, and this is two more things. People are 9 times at greater risk for a bloodstream infection with a catheter to other dialysis access options. So if you got a catheter, you are 9 times at greater risk for a bloodstream infection. All right. Now, will you get an infection? We don't know, but just know you're at greater risk. Also, people with catheters sometimes spend 27 more days per year in the hospital on average for people with a catheter compared to other accesses. And I'm like, why is that? If you got a catheter, again, an infection, they may got to pull it, put it on the other side. Catheter not working. Now you got to go get a procedure. You may have to get it pulled, get another one put in. You can ask many kidney warriors who have a catheter, how many catheters have they had? Someone tell you, so many I can't even count. Some people have so many catheters, it done affected their veins. And now they don't have anywhere else to go. This is serious business. And that's why we do these type of shows. Because sometimes people are not always able to get their questions answered at the facility because people are busy, or they may say, I don't know. And now you're left going on social media in the Facebook group chats or the groups, posing the question there, trying to get other people's opinion who may have went through the same situation. But everybody's situation is different. Now, if you got a catheter and you just started and you're like, man, Steve, I don't want this catheter. I'll go ahead and get it in my arm. This just makes me feel weird. To make the switch from a catheter to one of the safer dialysis access option, you got to talk to your doctor. If they haven't already came to you and set up an appointment with the surgeon to get vein mapping. But I encourage you to get a second opinion. Just like we do when we get somebody to repair something and you go get another opinion, go far as your surgeon. If you've never been to this guy, never heard of him, and they say, here, go to this doctor, and you don't even know the person, this is somebody they send you. Do your research. Just look up in Google for another surgeon in your town. Say, hey, I want to schedule an appointment to see surgeon. They say, oh, you can't see him until 3 months. I say, okay. But don't let anybody coerce or guilt trip you into getting this out until you're able to get two opinions. That's just my opinion. Okay? Now, when you go to the surgeon and they do the vein mapping, they're going to see, first they're going to use your non-dominant arm when they're ready to put the access in. We can really talk about that. They want to check your veins and see where the good ones are at. Now, what we're about to talk about is known as a permanent access. AV fistula, arterial venous fistula. When they say arterial venous, the artery in the vein. Or AV graft, which is, we're going to talk about that. But let's talk about the fistula. This is the access that they consider gold standard, that they want people to try to get first. And you're like, why, Steve? Why do they want you to get the fistula first? Because it's using your own veins. That's the most natural as you can get it. Using your own veins. This is a man-made device. The graft, the tubing, man-made. Your own veins, natural. So let's look at what a fistula is. A vein and artery that are surgically connected. A vein and artery that are surgically connected. They create a large, thick vein underneath the skin. And if you're on dialysis, you've probably seen other kidney warriors. Some of them may have what some people refer to as bumps or knots, but they're called aneurysms. And those knots or those bumps come from sticking this needle in the same area each time you come to dialysis, when you're supposed to rotate the sites to prevent that from happening. Now, once the fistula is ready to use, This vein allows for good blood flow during dialysis and make repeated needle insertion easier. But let me tell you something. Unfortunately, you may have some patients whose veins don't develop as well as others. And so when we first start sticking off, they use a smaller needle. And then they advance up to this large one. But in the beginning, sometimes it may be hard to find that fistula. And you got different people come over, sticking you. They got to put the tourniquet on. Some people have been stuck 3, 4 times. 5 times they're trying to get the needle in. And they sitting there holding their arms, squeezing for dear life. Let's talk about the benefits of using a fistula. The benefits of it. It's the preferred dialysis access by most kidney doctors. It's best overall performance with dialysis. Lower chance for infection compared to all other access. And it's long lasting. I know that because I met a patient back in the early 2000s. God rest her soul. She had her fistula 37 years. And I believe she was the longest person at that time in Maryland with an AV fistula for 37 years, the same one. Now, how is someone, we know everybody's different, but how is Josie, that was her name, can't remember her last name, how is she able to keep her fistula going for 37 years? Now, let's look at some considerations for a fistula. May be visible under the skin. Takes time to develop, usually 6 to 8 weeks. Some may even be longer because of your veins. You got to go back to the surgeon because they say, oh, we got to raise the vein up or we got to widen it. This is why I say get 2 opinions. Because like they say, the art of medicine is not an exact science. Because you go to one surgeon, he may tell you something different. You go to the other one, he may disagree with the first one. And now you're like, who's right and who's wrong? Also, consider requires the use of a temporary access while the fistula is maturing. So you're going to have this in while your fistula is maturing. And normally they don't like to take this out until you got maybe 3 or 6 successful sticks. And then they're going to take it out. Because what if your arm keep messing up and they take this out and they still having trouble getting your arm? Now we don't have, in what case you get infiltrated and your access is new. Many warriors been through this. And you can't go above the infiltration because there's nowhere to go. You're like, do you still got your catheter? No, I just got it taken out last week. And we'd be like, oh my God. We're like, that was too soon. Because we haven't really got any great sticks on you. Also, another consideration with fistula, they may fail to mature. Yeah, they may not even develop. Especially if you got diabetes or any type of vascular disease and no one is keeping track of it. And now you get on dialysis and you go to the surgeon and they doing the vein mapping and they say, you know, you got small veins. Then they say, but anytime you hear you go to a surgeon, you watching this, your mom, your dad, or yourself go to the surgeon and they say, you got small veins, but all in one sentence, be leery of that. Be very, very leery and ask questions. Because you know what that but means? It may not work. Now, these surgeons done thousands of surgeries. Come on, they've been in practice 10, 20 years. You don't think they know? You got some surgeons that start off with putting that fistula in the bottom part of your arm. And we know that the veins are small down there. I showed that on TikTok on a diagram that a surgeon sent me. And then your larger veins are up here. And this is what I'm saying. It's a medical opinion that the called a brain fog. But when it comes to medicine, the art of medicine is not an exact science, because you got one surgeon that say, I go down here and put the access. And you got another one say he goes up there. Now, why the difference of opinion when it comes to the surgeons? A lot of times when people start off in your lower part and you got some type of vascular disease or small veins, the fistula fails to mature, or they got to go in and widen it, get multiple procedures, only for them to say it won't work and we go up here. After all that trauma, and now you can't move your fingers like you used to because they done cut a nerve down here or a vein and rerouted something. Now you got what they call Still syndrome. Hands always cold, numb. It wasn't like that before this guy or woman start cutting, doing Edward Scissorhands. So when you go to the surgeon or your parents or your loved one, and if you're watching this, ask questions. Ask questions. Because remember, these guys, they got to get paid. They got to pay their bills. And so if you got somebody continually coming back and you're working on their arm, that's more money. It's not like when he does the surgery and you come back, copay, and something's wrong. We got to go back in and do this. That's not free. That's not free because he didn't get it right the first time. Hell, I experienced that with the dentist. Dentist took out teeth number 30 and left root tip in. And he gonna tell me he gonna try to send me to an oral surgeon to do something he didn't finish. You got to be going crazy. Why you didn't finish the work? So, again, to save yourself any pain, trauma, or mental anguish, right? If you just started dialysis, your mom, your dad, your brother, your sister, your loved one, your partner, whoever, and they at the juncture where they telling them, hey, we're going to send you to a surgeon so we can go ahead and get this out and you get in your arm. You say, okay, but I'm going to get me a second opinion as well. Because one surgeon may say, we're going to go down here, down your lower arm. And the other one may say, we're going to go up there. Now, who are you going to believe? Who are you going to believe? Now you went to both appointments. One says here and one says there. Now what do? Now you go on social media into the group and say, hey, I just started dialysis and they sent me to a surgeon and I went and had a second opinion done. One surgeon says, get it in the lower arm, and the other one says, get it in the upper arm. I don't know which one I should believe. And then here you come, people in the chat. Oh, I got mine in the lower arm. That worked. Oh, I got mine in the upper arm. It's a matter of opinion. But if you ask me, and almost my 4 decades, those you don't know what a decade is, 10 years. Those to the new people, to the millennials. No, but my almost 40 years working with patients on dialysis, I always seen I seen patients have it here and it works, no problem. And I seen patients have it up here, work no problem. I seen patients, they get it started off and it doesn't even mature. And now they got to go up here. And the reason for people, the doctors say they go up here first because they don't want to go below if it doesn't work. And people say up here, they start here because they want to go up there. I mean, I'm sorry, because if they start here and it doesn't work, then they can go up there. So I done seen people walk around here 3-4 access. One right here, one right here, and they get over here, now it works. Why is that? Why 3 surgeries? But not all patients are suitable for a fistula because of the veins. They may have peripheral artery disease, peripheral vascular disease because of diabetes or whatever else is going on with their vascular system. This is why education is important. Now, let's talk about the other access, the graft. Now, I don't have any of that flimsy material that they make the graft, but just imagine the tube, something like this, but a little bit more flimsy. And they stick it under your arm and connect one end to your artery, and they connect the other end to your vein. And so this is your artery. You stick the needle, the blood is coming out, and this is the vein or the venous side, and you got the needle going in, you got the blood coming out, going through the machine, getting clean, and then the needles in here, and it's coming back through the needle. And this is how like a horseshoe graft, most of them. Or it could be a straight graft. But this is what they say about a graft. It's a vein and artery that are surgically connected together by a synthetic tube placed under the skin. So you got a synthetic tube. And this is the second choice of access, is the graft. And it's a synthetic tube that's placed under the arm. So now we're not using your natural veins. We're sticking in a synthetic tube. Now, needles are inserted in the synthetic tube rather than your veins. And you can see why this can be some problems, being man-made. Now, it's only two benefits of a graft. Two benefits of using this. Can be easily implanted with a relatively minor outpatient surgical procedure, and after surgery can usually be used in 2 to 4 weeks. 2 to 4 weeks, opposed to the fistula is 6 to 8 weeks. You see the cut down time? Now let's look at some considerations. Increased potential for clotting, very high. And you're like, Steve, how is that? We got this synthetic tubing, which is man-made. And when you got blood going through there, remember, blood tends to clot on foreign material. That's why when you get a stent, what do they give you? Blood thinners. You have a heart valve placed. Give you what? Blood thinners. Any type of device or something that you may have put in, they may or may not give you blood thinners. But with this graft, say if your blood pressure drops, goes down into the 80s, 70s, while you at home or your parent. Less blood is coming from the heart. And now if it's not moving through there and if it slows down, the potential of clotting becomes greater. And one thing I want to say that came to my mind as I was thinking about this, if you go to dialysis, your parents, your loved one, and you taking blood pressure medicine, and your pressure is dropping during dialysis, you may want to talk to your doctor if you're taking blood pressure medicine before dialysis. We always suggest if one is taking blood pressure medicine in the morning, including the days that they go to dialysis, to hold that medicine until after treatment, or take it with you to dialysis, because if you take that medicine before dialysis for many patients and you pulling off a lot of fluid, you may not be able to pull it off, because see, dialysis, when we're pulling off fluid, what technically is supposed to happen, your blood pressure is supposed to come down as we pull in the fluid. But when you take a blood pressure medicine on top of that, now you got a double whammy effect, because you got the blood pressure medicine lowering your pressure, and you got the ultrafiltration of the fluid removal bringing down your pressure. So that just came to my mind as I was talking about your blood pressure dropping and causing this to clot off. So if you got this, you at increased risk for potential clotting. Another consideration, higher likelihood of infection, because it's man-made. And see, when it's under your skin, right? And this is where hygiene is important that a lot of patients don't realize. When you go into dialysis, right, for the most part, most dialysis clinics, when you go in right near the scale, there's a what? A sink. And guess what? That sink is there for a reason. Not just to wash your hands, but to wash your access with soap and water. And what generally happens, people come in, get on the scale, and walk right by the sink. And now you got a technician or a nurse may only have 1 or 2 alcohol pads. They don't care. They're not thinking about, using 6 alcohol pads like I do. I'm not really that conscious enough to say, let me use 6 pads. They may have 2, and they may strip up and down, or they may do this, rubbing around the same area. When we know, and it's taught, that when you clean in the access, you start from the inner and move outer, because you're moving germs away from where you're going to put this needle in. Now, if you have a graft, which is man-made, and you still got germs on top of your access, well, guess what? If they penetrate using the needle, the germs can get right into your access. And by being man-made, it loves to breed germs. I've seen people had to get their whole graft removed because it got infected. This is a whole different ball game. See, being diagnosed with kidney failure is one thing, starting dialysis. That's one thing. But many people don't know the after part of that, when it comes to the access, if you got catheter and it's not working, and now you got to go to the access center, disrupt your day to get this replaced. Or you having issues with your arm, something that you didn't know that was going to take place. It's a whole different ball game. That's why I said once someone gets on dialysis, it's a new normal. It's a new normal. And that's why I wrote this second book, the Dialysis Patient Handbook of Information. Because now you're going through a daily or every other day process that's going to be a part of your life from here on out, or until you get that transplant, or we move on to glory. And if you want to get this book, it's available on my website, stevethekidneynurse.com. Here go some other considerations. Not likely to last as long as a fistula. Yes, do you know these graphs? The average use, 5 to 6 years. 5 to 6 years. And see, this is why when you start dialysis, one should have all the cards laid out. Even when it comes to your access. Because look, if they saying that this is not likely to last as long as your fistula, and you get a graph, and the average use is 5 years, what if you only get 3 years? Then what? I'll tell you what. It's another graph. Now you got 2. That's how you see people walking around, got access here, one here, here, and then they had to go to the leg. I've seen that in my 38 years. I've seen people exhaust all their options, and they had to put a catheter. It's called a, oh my God. Oh, translumbar. And the catheter comes out from your back. And I've seen some people that ran out of options that they just signed off dialysis because they were just tired of going through it. Again, this is no joke. Now, also requires the use of a temporary access while the graft is maturing. So we already know you're going to already have this. And they put the access in. And the graft is not suitable. The graft is not suitable for all patients. So let's just look at how to take care of the access. I talked about it. We got 10 minutes left. But what I got takes more than 10 minutes. Takes more than 10 minutes. No one else is talking about this. I guarantee you. And thank you for your time. Because let me tell you something. Millions of people deal with this on dialysis all across the world. Some have access to education, dialysis education, and some do not. And that's why Moses and I do this show, to help people who do not have access to this type of information that are undergoing kidney dialysis. So let's talk about how to take care of your access if you have a CVC, which stands for central venous catheter. Wear a mask during your dialysis treatment to keep from breathing germs into your catheter. Always wash your hands before you touch your catheter. Keep your bandage secure and the exit site clean and dry. You know the bandage I'm talking about. Look out for signs of infection every day. And what that may be, signs include increased pain, fever, dressing wet with drainage. If you see some greenish stuff on that dressing that you haven't seen before, that's a telltale sign of infection. Redness or warmth around the dressing. Tell the nurse if you have pain or drainage from your catheter. Call a clinic if signs of infection develop on a non-dialysis day. Also, never use scissors or sharp object around the catheter. Even if you had dialysis and the nurse comes in because they're trying to get something around there. Hey, no, please do not have those scissors around my catheter. I kid you not. I had a colleague that told me that they seen a colleague use scissors around the catheter and she nicked a pinhole in the thing and it started leaking. Make sure the catheter is secured to your body and positioned to avoid getting pulled out. Some places they tape it down. Because we had incidents where patients come in and say, hey, my catheter came out, and they holding the catheter. And like, I didn't even bleed. And you would think some people, like, if this came out, you would bleed to death. But that's hardly the case. Also, avoid clothes that rub or pull on your catheter. Also, if your catheter do come out, lie flat, okay? Apply pressure to the site and call 911. Now, if you have a fistula or a graft, listen and feel the vibration, the thrill, several times a day. And you can get yourself a stethoscope or put your access up to your ear. If you do not feel or hear, immediately call that surgeon's office. Don't call a dialysis unit. Call the surgeon who put it in. And then call the dialysis. And tell them you clotted. But waste no time getting in that surgeon's office. Because they may want you to go to the access center. Now, there's nothing wrong with the access center because they're there for quick things in and out. But do you want somebody, if you went and had work done on the original person, or say you was a surgeon, or you did work on somebody You want them to come back to the original person who did the work. Somebody else don't know my work. So why go somewhere else and let them do the work that your surgeon does? Now, they may say, okay, you can go there because they may be busy or tied up appointments and can't get you in. But you just want to be careful going to someone else, having them declotting your arm. Do not wear tight clothes or jewelry on your access arm. And the reason being because it can compress. Like say if you got an access up here, right? And you roll your sleeves up and they get tight, it can squeeze down and compress your access, thus preventing blood flow going through because you're compressing it. Also, it's suggested that you not carry anything heavy or do anything that will put pressure on the access. Also, you probably heard this one. Do not sleep with your head on your access arm. You know how some people sleep like that? Or don't sleep on it because, again, you can compress down on the access, which can prevent movement of blood through the access. Do not let anyone, I mean anyone, use a blood pressure cuff on that arm or draw labs from your access. When the needle is removed, when you pull out the needle, press gently to begin clotting. Don't press real hard. Press gently to begin clotting. Too much pressure will stop the flow of blood through the access. Also, if you start bleeding after dialysis, which happens to many people, even at home, apply pressure to the needle site with a clean towel or gauze pad. If the bleeding does not stop within 30 minutes, call your doctor or your facility. Now, Steve the kidney nurse have come up with something to help you if you bleeding at home. I just don't advertise or put it out there, but it's on my website, and that is the HELK. This is the HELK, HELK, Home Emergency Lifeline Kit. And I don't want to say develop because, I don't know, some people may have their own. But I came up with this because people bleed out at home and you're rushing around looking for a towel, blood all over the place. Well, at least if you had the HELK and you had it in your nightstand near your bed, if you start bleeding, we got gloves in here, got a tourniquet, got some short seal Band-Aids, and we got 4x4s. And so if you do, you know where it's at. Hey, baby, or your caregiver, get the HELK. It's in the drawer. Here, tear it open. See where you bleed, put it on there. You got direct pressure on it. Even got a Lifeline care card in here. And again, this is available on my website, Steve the Kidney Nurse. Also, is it says, always wash your access with soap and water before each treatment. Again, that's why that sink is there. Take advantage of it. Seriously, go in and wash your access as well as if you got to scrub it. Because I'm going to be honest with you. The people, the caregivers at the unit, nobody's going to care for your access the way you do. Again, they may only have 2 pieces of alcohol pad and do that. And you're like, damn, that's it? That's why I say wash your access. You got to scrub it with that antimicrobial soap. Let the water rinse off the soap under the sink, dry it off, and at least you know if they didn't do a good job, at least you did. And last but not least, do rotate your needle sites. This is where the aneurysms, those lumps that people refer as, they're called aneurysms because when you stick in the same area repeatedly and you got that high velocity of blood coming through your access, at some point that area is going to get weakened. And then that's where it's going to expand and cause that aneurysm. So that's why we say rotate. If you stick here today, go 1 to 2 finger breaths above the last stick and have them stick there. And keep doing that. Keep going up and then come back the next week and go between. You got to rotate. I've seen it happen. I've seen people that access don't even look like an access. Like, damn. Like, yeah, I rotate my sites. That way you're giving an area a chance to heal. Let me read my comments. Thank you for the comments. Oh, hey, Nikki 4010, thank you for watching. And thank you for sending the speedy recovery to Brother Moses. Oh, yeah. I was talking about, I'm sorry, the access when they stick it, and rotating the sites. Make sure they rotate it. Because if you don't, you could possibly take longer to bleed if you're sticking in the same area. You can get an infection. It may take time to heal. It's all kind of stuff that can happen. Okay. Hey, Latasha, how you doing? Thank you for watching. Thank you. I appreciate you, Nikki. Thank you. Hey, Peach Teach. PT, thank you. Yeah, thank you. I really appreciate you coming on. And, any one of you are more than welcome to reach out to me behind the scenes. If you have any questions, concerns, you just go to Steve the Kidney Nurse website and where it says contact, and I'll get an email. I have no issues responding right away. Nikki says, so your opinion, where should they place it? All right. So again, this is my opinion, but make sure you check with the surgeon and ask questions. But if you're getting an access, a fistula, I've talked with surgeons, even had them on my show, a surgeon that suggests to start up top, because this is where most of the larger veins are at. Especially, see, minorities, we are already have small veins. Now, if you got diabetes or any other condition, they even may make it worse, because your veins are small and they connect two together, and they're going to have you squeeze the balls for exercise. Let me see if I can find it. One. I can't find it, but they got these little small, here we go, I got one. Look like this. And they give it to you. And some places don't give you nothing. But these, what I'm saying, that I got to get people on my TikTok who subscribe. I want to send them one of these. I just got to get the address, the people who subscribe to me on TikTok. But this could be used as a stress ball. You had dialysis and they're about to stick you. And, some people grab on the seat or clutch their hand, clutch their hands or grab on the edge of the chair. And so you had this. Oh, you said that's you, PT. That's me. I have small veins. And Nikki 4010 says I have small veins with vascular disease. I'm Thursday. Oh, you go Thursday to see the surgeon, Nikki? Yeah. PD is definitely a good option. If you, okay. If you got peripheral vascular disease and small veins, you may want to seek or check in the PD before you get anything done. I mean, any cutting, any of that with vascular, I would seek the option of a PD. So they push home dialysis because one, it's a little more money, but no, the government is trying to push that because it's becoming, in-centers is really being overwhelmed. But with home dialysis, you have a little bit more freedom, especially if you work. Now you don't have to send a dialysis around your job. You can send your job around dialysis. You can send a dialysis around your job with home dialysis. So say if you do PD, right? You can either do it on the machine, do it at night, and when you get up, it's done. You go to work. Or you could do manual, do it through the day. You do treatment at work. Like, how you do it at work? You could be in your room and have your office and have a pole and have a bag hanging up. And while you're sitting at your desk, it could be putting the liquid in. I knew a lady, God bless her heart, that worked picking fruits in the fields and did peritoneal dialysis. And during her break, she went to her car and did the exchanges. So if I was to go on dialysis, which I said I would ride this till the wheels fall off, but if I were to go on dialysis, I would do home dialysis. And I would do PD, bar none. That would be my preference. if I did dialysis. Because like I said, I will ride this until the wheels fall off, and then I may not even do treatment. But that's me. That's me. I'm not suggesting that for anyone. But oh, really? Yep. I've been checking out PD, concerned about infection control in home environment and keeping it. Well, let me say this, P-Teach. You're not going to get any sterile environment. Okay? You're not unless you're in the hospital, in a room, and it's sterile, the OR, something like that. But at home, you got to have a clean environment. And so when you look at PD, right, and your nurse, the PD nurse will train you, and when you do the exchanges on what you should wear and how you should clean your access site and with what, and when you're doing this, not to have no fan turned on and stuff like that. And you may not want to have an animal. I don't know. Some people do. But you can definitely, if other people can do it and they having a great life and still enjoying the things that they love to do under the, circumstances, yeah. And, again, it's a lot of supplies. And this is the thing about it. And see, this is where the waste comes in. Is you have somebody have all these supplies, PD supplies or home dialysis, and then they get the call. They get the call. We got your kidney. And now they got the call and they got a kidney. What happens to the supplies? You can't give them away. Who wants more PD supplies? And they stacked up at their house too. Like we gotta get a damn warehouse or storage. So what ends up happening, the company doesn't take it back. No. Even if you didn't open it, they're not going to take it back. Guess what? It goes to waste. Just like a lot of things in dialysis. Money. You can have a box of lines, a box of filters. And if it goes past the expiration date, guess what? We got to throw them away. Even with medicine, you may never use it in dialysis. Have a whole 25 pack of genomycin, 80 milligrams, not used. And now they're going through because the state on inspection may come. And if you see that it's expired, they throw it away. And that same medicine or lines can go to our brothers and sisters in East Africa or other parts of the country that don't have access to a lot of this. But nobody talks about it. Yeah, they could take the supplies, but who's going to do it? Unless they got somebody on PD. And then again, they expired. They expired. The only place that stuff can go where they don't care about any expiration date is overseas. You was on that med for 1 month. Wow. Yeah. So anyway, we kind of over 16 minutes of the show, but again, I want to send speedy recovery to Brother Moses. Definitely want to see. Hope you could be back here next Sunday. We kind of been here and there with the show because I was involved in the automotive accident back in May, early part of May, and I hurt my back. So, and then there's other things just coming in the way, but we're back with a new season. Same information. As I said, when in dialysis, the information is kind of rotated. The way they have it set up, each month, there's a education that they go over with the patients. And now, they don't even go over it with them. They're given this sheet of paper and say, can you sign that I gave it to you? Not knowing if the patient can read or not. And many people are not going to admit that. Can you read this for me? I can't read. So they'll get the paper and that's why you may see it still sitting at the chair side when the patient gets up and leaves. And the technician or the nurse throws the paper in the trash. Well, that was the education. And the patient never forgot about it. So let's go over 4 things before I get out of here for caring for your access. Because your access site is your lifeline. Now, keep your fistula graft healthy. And if you notice a problem, again, act quickly to get it treated as soon as possible. Now, I'm going to tell you how it's 4 things I'm going to go over and how it's supposed to be treated. And this is for the access. First one, infiltration. Infiltration. Mike, Steve, what the hell? This occurs when the needle, this needle right here, punctures the fistula or graft and cause bleeding under the skin. So when somebody's sticking and it goes in and this part nicks or goes through the access, creating another hole, the blood is going to go through that hole. And now this is where the swelling called a hematoma comes up. Now, this is how we treat an infiltration. Day 1, apply a cold compress like ice to reduce the swelling. 15 minutes on, 15 minutes off for 24 hours. Do you follow me? Day 1, to treat infiltration, apply a cold compress to reduce swelling. 15 minutes on, 15 minutes off for 24 hours. Day 2, apply moist heat to help your body absorb the clotted blood. 15 minutes on, 15 minutes off for 24 hours. Do you follow me? Day 2 of an infiltration, apply moist heat to help your body absorb the clotted blood. 15 minutes on, 15 minutes off heating pad. 2, aneurysm. That's what I'm talking about, the bumps. They call aneurysms. This occurs when the area in the fistula or graft bulges. We see that bulge. Some people call them knots, but it's a bulge. Warning signs, wait a minute. An aneurysm. This occurs when an area in the fistula or graft bulges. Warning signs of a possible rupture include rapid growth, tenderness, discoloration, or tight, shiny skin. How many people you seen, or even yourself, on your fistula, and you got the knot, but at the edge, it's real shiny, discolored, almost look like it can pop. How to treat this? If you think your access may be at risk of rupturing, and we've seen it happen. It can happen. And that's a serious emergency. We had, not to scare anyone, but I've had, and this is one of my reasons for coming up with the help, I had a patient access rupture at home, and they passed away. If you think your access may be at risk of rupturing, call your doctor or nurse as soon as possible, ASAP. I'm not talking about no ASAP Rocky. If the area ruptures at home, see, they talk about because they know it happens. If the area ruptures at home, immediately apply direct pressure or a tourniquet. Now, if you at home and your access rupture and you in bed, what's the first thing you're going to do? You may panic. Do you got a tourniquet at home? It says, if the area ruptures at home, immediately apply direct pressure or a tourniquet. Do you got a tourniquet at home? I'm not talking about no towel, no your shirt or your belt. I'm talking about a tourniquet that they use at dialysis. Again, this is where the help comes in. The home emergency lifeline kit that I developed. You got a tourniquet right there. You got 2 pairs of gloves. You got short seal Band-Aids. You got 4x4s, and you got the care card to tell you how to act and move on this. We're not playing here. And if you want the help for your loved one or for yourself to help prevent you or your access, if you rupture, you got something right there at the bedside, go to SteveTheKidneyNurse.com. We ain't playing over here. Also, call 911. Bleeding. When a fistula or graft has been weakened by repeated punctures, that's the one, we call it one-site-itis, sticking in the same area. When a fistula or graft has been weakened by repeated punctures in the same area, unexpected bleeding may occur between dialysis treatments. This is how you treat it. Apply direct pressure for 5 minutes or until the bleeding stops. Cover with a clean dressing once the bleeding stops. If the bleeding doesn't stop, continue to apply pressure and go to the hospital immediately or call 911. Let your care team know if you are bleeding between treatments. Again, if you bleeding at home and you ain't got the help by Steve, the kidney nurse, then you ain't with the time. This kit can potentially save your life or your loved one, especially if they bleeding at home and you never experienced that before, and you rushing around trying to find a towel, and you just put the towel over it like that, don't really got the site covered up, and you don't know where it's bleeding from. At least with the help, you fold that 2x4x4 up, and it takes one time to look where the hole is, put it right over it. Direct pressure. Last one is a clotted access. Now, there's nothing you can do about that. You can do prevention, but a clotted access is a decrease in blood flow where a clot is blocking the access. So a clot is preventing the blood to flow through the access, whether you have a graft, man-made, or officially your own veins. A clot is blocking the access, preventing blood from moving through there. And now this has to be surgically removed. Now, signs of clotting can include redness, pain, loss of vibration when you touch your access, and loss of the low pitch swooshing sound. When you put your access up to your ear and you hear that swoosh, swoosh, swoosh. How to treat? Notify the care team or your surgeon immediately. Don't wait around, because you could potentially lose the access if you wait too long. Now, a clot could delay your next treatment. So that's why as soon as you find out, it's like on a Saturday or a Sunday, say you had treatment Friday, and you find out, we know stuff don't open back up till Monday, but if you could call, leave a message on the answering service for the surgeon's office or whoever's on call the office. They may have somebody on call. So, with that being said, it's now time to end the show. We're like 30 minutes over, but the important is valuable. The information is valuable, and it warrants us going over 30 minutes. PT says, yes, Steve, interested in more info on new laws or recent issues in the community for CKD patients. Thank you, PT. Please reach out. Finger red number 1. Quickly, ASAP, take action. Yeah. Oh, anytime, Nikki 4010. If you have any questions or concerns or comments, You can always reach out to me, stevethekidneynurse.com. Hit my contact, and I'll reach it. Email stevethekidneynurse@gmail.com. You can hit me on most social media platforms, X, Instagram, Facebook, and TikTok. I'm mostly on TikTok because that's where I get most of the love. Not saying I don't get love from any other platforms, but yeah. But yeah, please. And also, before I get out of here, just know that I finished my 4th book, which is Navigating the Dialysis Journey, a guide for families. So now it's going to be 4 books that I done did within a 4-year span, all trying to help individuals dealing with kidney disease or at risk for diabetes, hypertension, or kidney disease. This is the latest book, Conquering the Big 3. So be on the lookout, because this is for families. Like, if you want your family to understand, you may be on dialysis, you're like, my family, they don't understand what I'm going through. Thank you, Latasha. I appreciate it. You know, my family, they don't understand. They just don't know what I'm going through, the emotional, the physical. Well, this book, Navigating the Dialysis Journey, a guide for family, is going to be that guide to help your family understand. And they'll have a tool to help navigate this journey with you, so you don't feel like you're alone. Now, unfortunately, some people don't have families. But if you have a caregiver or someone you consider family, this can be a great reference tool or guide for them as well. No one is out here doing this. Boots on the ground, giving you everything right there so you can make a conscious choice or decision on what you need to do to help yourself navigate through this journey we call kidney dialysis. With that being said, thank you guys and girls for joining Kidney Hub East Africa. I am half your host, Steve the Kidney Nurse, wishing my other better half, Moses Kennedy, speedy recovery. Look forward to seeing you next week. Same time, same channel. With that being said, thank you to, let me not forget, people who joined Nikki 4010. Thank you. God bless you. I'm going to be honest, this is my first time seeing you. You may have been here, but thank you so much for your support and tuning in. I really appreciate it. Latasha, thank you as always. I appreciate your support, your unwavering support. P-Teach, God bless you. Thank you. You never fail to come through on YouTube. And I want to say this because you always been faithful with the YouTube. If you reach out to my website and send me an email, I'll send you one of these books. You just tell me which one you want. This is for your unwavering support. Latasha, well, and you've been unwavering too, so I'll send you this one because you don't have kidney disease, but you may be at risk for this. But that goes to you too, Latasha. But P-Teach, you know, I know you say you're on dialysis, so whichever one, your choice, just reach out to me. Say, hey, this is P-Teach. I want to need your government name and your address to get the books to you. That's if you want it. That's to thank you for your support. And I mean, it's just been you, Nikki, and Latasha. And Nikki, you know, you've been, hell, I throw you in too. Because you've been faithful, you know, with the communication and comment. If you want a book as well, Nikki 4010, I send you one as well. So that's 3. Well, actually, it's 4 because somebody on TikTok sent me their address and government name. So that's 4 books that I got to send out tomorrow. That's if you guys want it. I mean, girls, I'm sorry. You know what I mean. But no, Leticia, P. Teach, and Miss Nikki 4010. Yeah, I know I don't have to, but it's just my appreciation. And that's just how I am. That's just how I am. So with that being said, you know how to reach me. If you want it, be more than welcome to send it out tomorrow or whenever you get a time to send the information. No rush. I'm just extending that out to you. So with that being said, we're going to end this with a PSA. God bless you. Love yourself and each other. Stay blessed and encouraged. And we see you next week, same time, same place.
Hello, I'm Darren. We have breaking news. More than 600,000 Americans have kidney failure. While the number of people with kidney failure is enormous, the number of people with its precursor, chronic kidney disease, is staggering. An estimated 31 million Americans, or about 10% of the US population. Diabetes and hypertension cause 2/3 of all cases of kidney disease. 1 out of every 3 Americans is at risk for kidney disease, and kidney disease is now among the top 10 causes of death in the United States. In addition, 9 out of 10 people with early to moderate kidney disease don't know they have it, putting their health in jeopardy. Are you at risk? For more information, contact urbankidneyalliance.org. The life you save may be yours.